Hello and welcome to the special ACR review podcast brought to you by the Immune-Mediated Inflammatory Disease Forum. I am Dr. Grace Wright, consultant rheumatologist in New York City and the president of the Association of Women in Rheumatology. Today, I am joined by Phil Mease, Director of Rheumatology Research at the Swedish Medical Center and professor at the University of Washington School of Medicine in Seattle, and Atul Deodhar, professor at Oregon Health and Science University in Portland. In this podcast, I want to discuss with my co-hosts what we found most interesting at ACR this year. There's been a lot of immune-mediated inflammatory disease content at ACR 2024, the most important of which we captured in our highlights brochure. There, we identified over 50 abstracts across the conference, which cover a wide range of key topics in therapeutics. And as always, if you would also like to be informed about key abstracts for lupus, you can access highlights brochures, preview podcast, and review podcast over on the Lupus Forum. So let's start with psoriatic arthritis. Philip, over to you.
Hello. Thanks, Grace. I'm pleased to be here to present to you some of the key abstracts in the psoriatic arthritis arena at ACR 2024. This first abstract, which was lead authored by Lihi Eder, is about sex and the response to medication. This is a passionate subject for Lihi. She has been really pioneering in this area and has done a previous meta-analysis which showed that with the majority of the biologic clinical trials in psoriatic arthritis, where there was disaggregation of baseline disease activity and response based on sex, male or female, she showed in that meta-analysis that in the majority of the trials where there was data that was disaggregated, the females had greater disease activity as measured by various composite measures, that including subjective elements, and also had less response or poorer response to treatment. The one exception to this was the JAK inhibitor class. This meta-analysis did not include the newer IL-23 inhibitors, such as guselkumab, and so that's what the focus of this particular abstract, number 2342, was. And as you can see from the bar graph, there was really no difference between male and female response in the pooled phase 3 trials of guselkumab, both in the bio-naive and bio-experienced populations. The responses that were looked at include ACR20 response, CDAPSA low disease activity and remission, enthesitis and dactylitis resolution, and skin disease. Also, patient-reported outcome measures, fatigue as measured by the FACIT and function as measured by the HAQ score, were similar. So this would suggest to us that we can be relatively confident that using guselkumab, we won't have a significant difference between males and females. She is in the midst of leading a large trial that the GRAPPA organization is doing called the SAGE trial, in which we are entering both males and females who are starting a treatment, either a biologic or TSD-MARD, and looking very carefully at all aspects, including hormonal status, the neurological aspects, the pain sensitivity aspects, as well as immunobiology of these patients. And so we hope to have more information about sex differentiation with the results of the SAGE trial. The next abstract is an interesting one in which BMS looked at biomarkers associated with pain in the deucravacitinib trial in psoriatic arthritis. Deucravacitinib is a first-in-class oral agent that inhibits tyrosine kinase 2. And this has been shown to inhibit a number of cytokines that are important in both psoriasis and psoriatic arthritis, including IL-23, interferon, and IL-12. What they did was they identified about 120 biomarkers to investigate and found that 11 of these were significantly associated with baseline pain score. Those are listed at the bottom of the slide and include certain inflammatory markers such as TNF, MMP3, CRP, IL-6, also several others, including VEGF, that are important in, for example, neovascularization. And they found that during the course of the trial, there was a significant drop in these biomarkers in the deucravacitinib treated patients, but not the placebo-treated patients. And also found, in addition to these particular biomarkers, that IL-17A, which were particularly associated with level of skin disease, also showed greater improvement in pain scores when the patients treated with deucravacitinib. So this kind of exploration advances our search for biomarkers in PSA that can help us guide treatment. And we're hoping that with all of this biomarker data in the future, we'll come up with either single biomarkers or groups of biomarkers that can be tested to teach us about pain response, but also general clinical response. The next abstract, number 2367, is one that I presented, which is a look at all of the phase 2b and 3 studies in axial spondyloarthritis and psoriatic arthritis in terms of safety in patients treated with bimekizumab. Bimekizumab, as you know, is an IL-17A and F inhibitor. So it's distinguished from the previously available IL-17 inhibitors, which are strictly IL-17A inhibitors. Those are secukinumab and ixekizumab. So there is some evidence translationally as well as really good clinical responses in general from bimekizumab trials that there may be some added benefit to inhibiting both IL-17A and F. So this is looking taking a very broad view of the safety data out through 2 years. And this represents 850 axSpA patients, 1,400 PSA patients, for a total of 2,500 patient years in the axSpA trials and 3,600 patient years in the PSA trials. So quite a large base. What they found was that the incidence of infection or serious infection in terms of events per 100 patient years was 1.4 in the axSpA population and 1.3 in psoriatic arthritis. As you know from your knowledge about events per 100 patient years with other agents, these are very low numbers. And so in terms of serious infections, we can advise our patients that the likelihood is very low. There were some fungal infections. Almost all were what I call surface candidiasis, so oral thrush, for example. There were no systemic fungal infections reported. IL-17 as a cytokine helps protect us from surface candida. And so it makes sense that if you inhibit it, that there will be some occurrence of these fungal infections. Most of these were mild. We could treat them with oral nystatin or occasionally a systemic diflucan, but and most of the time they occurred just once. And the patient was able to continue with bimekizumab and they did not recur. on a few occasions, there were patients that had repeat infections, but for the most part, they were not a big issue. We do advise patients about this possibility, but it tends to be mild to moderate. The other key point to mention is that there were some cases of IBD. They were infrequent, and they occurred both in patients who had had a previous evidence of IBD, Crohn's or ulcerative colitis, but were not active at the time of admission into the trial. But there were also some new cases. Again, this is something that we've seen with the IL-17 class, and so we are careful to ask patients about any history that they may have of inflammatory bowel disease and consider not using an IL-17 inhibitor in such cases. What's absent here is we're not seeing meaningful issues with major adverse cardiovascular events. We don't see a signal for malignancy, and so in general, this is a relatively safe type of medication. Here, this particular abstract is also presented by me as a poster, number 2368. This was bimekizumab-treated patients with active PSA showing sustained improvements in pain and fatigue up to 2-year results from the phase 3 studies. As you know, the two most important clinical issues for patients when we ask them in focus groups or do surveys, number 1 is pain, and number 2 is fatigue. These are the troublesome symptoms that patients have, so showing improvement in pain and fatigue is critically important. And that was indeed the case here, where we saw prompt and then sustained effectiveness with bimekizumab, and in the placebo-controlled period, clearly better than placebo in improving pain. Over 50% of the patients had greater than or equal to 50% reduction in pain. And in the pain research world, a 50% improvement is considered a major improvement for a patient. It's really significant. And then also using the FACIT-Fatigue score, we saw an improvement in fatigue. And increasingly, this is recognized as an important issue in inflammatory disease patients who have some central nervous system contributions to the phenomenon of fatigue. And so improvement in not only inflammation, but other factors centrally lead to improvement in fatigue. A new medication that is in the pipeline is sonelokimab. This is a novel IL-17A and IL-17F inhibiting nanobody. So the nanobody technology is a fascinating one in which you deliver the effectiveness of a particular drug, not in the form of a big 150 kilodalton immunoglobulin, but in a small package. In this case, this particular drug is 40 kilodaltons in size. And what we've seen in cancer treatment, as well as certain translational animal studies, is that using these nanobodies can potentially get into tissue areas that are difficult to penetrate more effectively. And this has been shown in the cancer world, where getting into cancer nest is very difficult for treatments, and this improves that. So what was shown here by Ian McGinnis in this oral presentation was the 24-week data for the phase 2 trial of this drug in psoriatic arthritis. There are approximately 40 patients per arm. And what we're seeing in the upper graph as an ACR 50 primary endpoint, and each of these pairs of bars on the left, we're seeing the 12-week data, and then on the right, the 24-week data. And as you can see, there's further increase to significant levels, over 60% of patients achieving an ACR 50 response at the 24-week time point. In the lower graphs on the left, we're seeing minimal disease activity achievement. As you know, MDA in psoriatic arthritis is 7 different items, including tender and swollen joint count being less than or equal to 1, enthesitis score being less than or equal to 1, pain being less than 15, patient global being less than 20, and so forth. So trying to get to a low level of activity in joints, skin, and theses, and patient-reported measures. And if you get 5 of these, 7, then you're in a state of MDA, which we know is associated with better outcomes in general, better function, better quality of life, less radiographic progression, and so forth. And again, same story. We're seeing patients who had a certain amount of MDA achievement at week 12, but this is still climbing at week 24 to levels that we haven't seen. This is over 50% in patients with psoriatic arthritis. And so this really speaks to the efficacy of this agent. And on the lower right, we're seeing simultaneous achievement of an ACR 70 response along with PASI 100, which is complete clearance of skin disease. Again, very high levels of achievement of this. So this is good information to support the further development of this drug and its proceeding into phase 3. The last abstract to present is another new agent, which is a tyrosine kinase or TYK2 inhibitor known as zasocitinib. I previously showed you some pain biomarker data with the first of these, deucravacitinib. So this is the second of these agents to come along and move ahead in psoriatic arthritis trials. What we're seeing in this phase 2 trial, in which there are approximately 70 patients per arm, is achievement of high thresholds of response. And at week 12, we see high levels of ACR 20 response, levels of MDA response of nearly 30% in the 2 higher dose levels. And then in the lower right, we're seeing a type of almost a heat map-like representation in which on the left-hand side of each pair, placebo and then the 3 different doses of zasocitinib, we're seeing where patients started in the trial with dark gray representing moderate disease activity and lighter gray being high disease activity. And then moving at the 12-week mark to being much less in the moderate or high disease activity arena, and instead transitioning to low disease activity or remission. The darker maroon color is remission, and the pinkish color is low disease activity, as measured by the DAPSA score. So this gives us confidence that higher levels of treatment response can be achieved with this new TYK2 inhibitor, zasocitinib. So thank you very much for your attention on these exciting abstracts on psoriatic arthritis.
I am now going to highlight some of the important topics covered at ACR 2024 on rheumatoid arthritis. So we'll start off with looking at a few abstracts on upadacitinib. And here we have abstract 1380, in which the authors, this was led by Manish Jain, showing rapid and clinically meaningful pain improvements associated with upadacitinib in patient-reported outcomes for those with rheumatoid arthritis. So the background behind this here is that we know that pain is an important component for patients, and we know that this is an important part of their patient global outcome measure. So the authors here investigated if clinically meaningful pain improvements were associated with greater improvements in other patient-reported outcomes in patients either treated with methotrexate with an inadequate response or biologic DMARD with an inadequate response, and then moving on to upadacitinib 15 milligrams. And what we see in the graphs on the right, looking at both BDMARD IR patients and methotrexate IR patients is that those patients who had a meaningful improvement by week 2 compared to those who did not, a greater proportion of them reported improvements at the level of an MCID in other PROs. So for the bio-DMARD IR population, these changes were noted both in the HAQ-DI and the SF36 at week 24 for those who met that threshold of pain improvement at week 2. And for the methotrexate inadequate responder group, a greater proportion of patients had MCID improvements in all PROs measured at week 26. So what we see here is that pain is a nice predictor for us. If our patients have improvements by 2 weeks, we can expect improvements across the spectrum in multiple other patient-reported outcomes, regardless of whether they're starting off as only stepping through methotrexate or having gone through biologics. And this was a strong correlation for our patients in rheumatoid arthritis. So again, a nice tidbit for us in clinical practice. Now, moving on to the second study, this was a real-world analysis of upadacitinib in RA patients, really trying to understand the improved safety and outcomes. And this, again, is in the RADIUS cohort, abstract 1390. This study aimed to evaluate the efficacy of the DAS28-CRP, using that as the measure, and safety of upadacitinib in treating RA in routine clinical practice. So we know that our clinical trials come with a series of inclusions and exclusions and may not include all of the patients that we routinely see in clinical practice. So it's important to have analyses that look across the spectrum of the patients that we treat on a daily basis. Some of the interesting results here were that there actually were able to see important outcome measures 3 months after starting treatment. In fact, 1/3 of the patients were in remission, 20% were in low disease activity, 42% in moderate, and less than 6% in high disease activity. And 6 months after starting treatment, these numbers improved significantly, with 45% of patients in remission, 25% in low disease activity. So here we're already at about 70% in low disease activity or remission, 24% were moderate, and just under 5% in high disease activity. So this study really shows us in a real-world data set that upadacitinib as an agent in rheumatoid arthritis was effective, with more than half of the patients in this study by the end of the first year really showing low disease activity or complete remission, and presenting with no new side effects, really following the profile of what we saw in our clinical trials. So again, very important for us to understand how these drugs work in our usual routine clinical care. Continuing on, now we're going to look at the relationship between disease activity and adverse events in rheumatoid arthritis. And this was an integrated post hoc analysis of upadacitinib across the phase 3 trial program. This was presented by Roy Fleischman, and the number here for this abstract is 1393. So there's really been a lot of focus on the efficacy, but also the safety of patients treated with the JAK inhibitor class, and then really to say, how do we sort of predict who is going to respond, who's going to have adverse events, and what are the relationships and the intertwinings here between the disease activity and all of the inflammatory consequences that we know and the therapeutic effect of the drug. So this post hoc analysis assessed the relationship between disease activity and development of significant adverse events, and this was with upadacitinib 15 milligrams in the SELECT phase 3 program. So the plot that you see here really then shows, if you go towards the right on this Fisher plot, higher risk of this adverse event than remission, and lower risk than remission on the left side here. And some really important things were noted in this particular analysis. One is that there are a variety of comorbidities that track with rheumatoid arthritis that were present here. But also for the first time, giving us this insight into the impact of disease activity. So Cox regression analysis showed that patients with a high disease activity measured by CDAI had a 5-fold greater likelihood of either major adverse cardiovascular events or venothromboembolic events compared to those who were in remission, and this is over a 5-year period. So disease activity here really mattered. And in addition, patients with active disease trended toward a higher risk of developing MACE and VTE versus patients in remission, again, highlighting the importance of getting our patients into remission. Residual disease activity also significantly increased the probability of developing serious infectious events. Again, another important consequence that we have to deal with in clinical practice. And some other keynotes here were that for every 5 mg per liter elevation in the hsCRP, that increased the risk of MACE, VT, and SIE by somewhere between 7.1 and 7.5%, and the risk of herpes zoster was increased by 4.4%. So put this together, this really supports the importance of driving disease activity to remission, and that inflammation reduction is important in mitigating some of the risks of our adverse events, especially these of special interest. So again, really important data coming out of this post-hoc analysis. Now let's switch to talk about the effects of anti-obesity medications in rheumatoid arthritis patients. This was presented by Elizabeth Denti, and this is abstract number 2259. So we've known for quite some time that obesity is one of the comorbid conditions that our patients with immune-mediated inflammatory diseases may struggle with, and that there are independent associations with cardiovascular risk. In RA patients, both obesity and disease activity are independently associated with cardiovascular disease. And evidence to date suggests that obese patients maybe are less likely to achieve remission, and that weight loss, in fact, may improve disease outcomes for our patients. Recently, we've had semaglutide and tirzepatide approved for the management of overweight and obesity in our patients in the US. And so we now have the opportunity to explore some of these data points. But in fact, we're really in this data dark void with a paucity of data on the clinical impacts on our RA patients. We know this data across general patients with diabetes or those who are overweight with another comorbid condition. So here what was explored was really looking across the spectrum of the comorbid conditions that we see in RA, and then to see whether or not there were changes as important measures that may impact our patients' disease activity as well as their total wellness. So the first really important key result was that obesity-related comorbid conditions were prevalent in our patients with RA. So we know this to be true. Now we have numbers. More than 50% of these patients were dyslipidemic, hypertensive, and diabetic, and those numbers, in fact, were 60%, 56%, and 51%, respectively, and coronary artery disease was present in 16.4%. Patients treated with these agents had significant reductions in weight, BMI, acute phase reactants, their pain, and lipids during the study period. So again, looking at reductions in some of the cardiovascular risks, but also looking at some of the outcomes and the measures that impact our assessment of disease activity. When we think about the adverse events that were experienced, approximately 15% of our RA patients taking these anti-obesity medications had gastrointestinal side effects, and these are, in fact, the most common side effects associated with these medications. 42 RA patients who discontinued, we'll call these anti-obesity medicines during the study period. The most common reasons were gastrointestinal side effects, 23.8%, insurance issues coming in at 26%, and inefficacy coming in at 9.5%. So the key takeaway for us here is that the use of anti-obesity medication may be associated with improvement in cardiovascular disease risks and pain in our patients with rheumatoid arthritis. And now we'll look at the kinetics of response for a variety of agents used to treat rheumatoid arthritis. And this is abstract 0501, titled, How Fast Do JAK Inhibitors, TNF Inhibitors, Abatacept, and IL-6 inhibitors act in rheumatoid arthritis? This is an international collaboration of registries of rheumatoid arthritis patients, or the JAKPOT study. So the aim of this particular study was to evaluate and compare the short term, and that is within 3 months, effectiveness of JAK inhibitors and bio-DMARDs in RA patients in a real-world setting across multiple global registries. And we see here the key results shown on the right. In these plots, we're looking at time on the x-axis and the various measures on the y-axis. And in the crude analysis, what we found was that CDAI improved quickly in the first 2 months and then decreased at a slower rate. So really rapid initial improvements. The decrease was particularly sharp for the JAK inhibitors and TNF inhibitors compared to the other treatments that I mentioned here, which would be abatacept and IL-6 inhibitors. For function, trajectories also improved rapidly in the first few months and then stabilized. So we see this initial drop and then sort of a leveling off of those curves. But this improvement was noted to be slower in those patients receiving abatacept compared to other targeted therapies. What's not shown here is sort of where in the treatment journey all of these patients are, disease duration, all of those background effects, but really just thinking about the kinetics of this response. However, after adjustment, the rate of CDAI, HAC, and pain improvement was still faster with JAK inhibitors and TNFs compared to the other biologic DMARDs. So in summary for this particular analysis, the short-term effectiveness of JAK inhibitors, TNF inhibitors, interleukin-6 inhibitors, and abatacept differed, with the JAKs and the TNF inhibitors acting faster on disease activity, function, and pain in the first months compared to interleukin-6 inhibitors and abatacept, giving us, again, a little bit of insight across global registries, number one, in terms of the impact of these agents, and somewhat affected potentially by placement in the treatment paradigm. So that is a summary of the slides that I wanted to share with you on rheumatoid arthritis presented at ACR 2024.
Thank you, Grace. So the big news at the American College of Rheumatology this year was the posters and oral presentations about bimekizumab. Bimekizumab is, as already you have heard from Philip, is a monoclonal IgG1 antibody that selectively inhibits IL-17A and IL-17F. Now, this drug is recently approved in the US. However, the trials have been completed for about over a year or even 2 years. And the drug has been approved in Europe even for a longer period of time. And because of that, even though the drug is relatively new in the US, the studies that were presented at ACR actually went up to 2 years. And so the first abstract, which is 0597 by Fabian Prof that I'm going to discuss, shows the results of the clinical responses over 2 years in patients with axial spondyloarthritis treated with bimekizumab. And so there were 2 studies, B-Mobile 1 and B-Mobile 2. B-Mobile 1 was on non-radiographic axial spondyloarthritis. B-Mobile 2 was on ankylosing spondylitis. These studies went up to 52 weeks, and the patients who completed the studies and wanted to participate and continue the drug went into the next study called B-Moving. And this B-Moving is a 2-year open label study. What is being presented here is the first year of the B-Moving study and the first year of the B-Mobile study. So this is pooled results, and it shows that there is a stringent clinical response. So we are seeing 16 weeks and then 52 weeks and then 104 weeks responses in patients with axial spondyloarthritis participating into these 2 trials. And if you take a glance at the graphs on the right-hand side, there were high proportion of patients who achieved responses at week 16 that were maintained all the way up to 104. And these are ASAS40 or ASAS40 responses. These are ASAS-PR or ASAS partial response, partial remission, I should say, and ASDAS low disease activity, and even ASDAS inactive disease. ASDAS low disease activity is ASDAS score of less than 2.1. ASDAS inactive disease is less than 1.3. The interesting part is the graphs are looking at the non-responder imputation. So this is the strictest way of looking at the responses over 104 weeks. So their conclusion was bimekizumab maintained a stringent clinical response from week 16 to week 104 in axSpA with no new safety signals. The next, I'm going to shift gears and talk a little bit about secukinumab. This was a poster that I presented. This is safety of secukinumab from 69 clinical trials. These are all the clinical trials that they have done in psoriasis, psoriatic arthritis, axial spondyloarthritis, hidradenitis suppurativa, and this is updated pooled data from 69 clinical trials. So this is a large number of patients, 22,603 patients who participated in the clinical trials. Largest number of the patients who participated in the secukinumab trials came from psoriasis, nearly 13,000, about 5,000, nearly close to that, psoriatic arthritis, and about 4,000 in axSpA. Hidradenitis suppurativa was about 1,060. And so the exposure is 36,600 patient years. And so the most frequent adverse events were nasopharyngitis and upper respiratory tract infection and headaches. These are common for practically each and every drug that you look at. But the important part shown on the table, most of the table actually shows the exposure-adjusted incidence rates per 100 patient years of the adverse events of special interest. And since secukinumab is IL-17A inhibitor, we are interested in inflammatory bowel disease, malignancies, and MACE events and suicidal ideation are added because of the other drugs such as JAK inhibitors have cardiovascular events. Suicidal ideation can be a problem with patients with psoriasis and psoriatic arthritis. The bottom line is there were no new signals, but the numbers that we know. So the number that I always remember is 0.8 per 100 patient years for IBD. I tell this to my patients when I'm seeing them in the clinic, that if I treat 100 patients like you for a year, less than one patient would probably have problems with inflammatory bowel disease. And patients understand that better than per 100 patient years. But the bottom line here is that there were no new safety signals, and the exposure-adjusted incidence rates of these adverse event of special interest were very, very low. The next paper or the poster was also presented by me. This is predictors of clinical response to IV secukinumab. Intravenous secukinumab has now been approved in the US alone for the treatment of psoriasis, psoriatic arthritis, and axial spondyloarthritis. And this particular abstract, we were looking at the predictors of clinical response for IV secukinumab, and there were some interesting observations made here. What is shown on the right-hand side is the forest plot, and which were the baseline enthesitis, baseline clinical aspects which predicted which patients with axial spondyloarthritis are going to respond to IV secukinumab. Generally, in axial spondyloarthritis, we know that high C-reactive protein, male sex, positive HLA-B27, these are some of the predictors of responses. Here, interestingly, we found that those were not the predictors of responses. What were the predictors of responses were higher level of back pain, and I guess lower level of back pain actually causes some floor effect, and you cannot really go further lower than what you already have. But higher level of back pain, longer time since diagnosis, this also was an interesting finding. Usually earlier you treat, better the patient's response is, but here it was longer time since diagnosis, which in fact is a surrogate marker for disease duration. And the third one was lower body mass index, and this is not surprising. Patients who are overweight or obese, they actually have difficulty in getting the full response as somebody whose body mass index is lower. So that lower BMI is not a surprising thing. What was surprising was high C-reactive protein or male sex or HLA-B27 were not the predictors. To look at it the other way, it would tell us that IV secukinumab would also work equally well in females, equally well if patient has got lower C-reactive protein, not high C-reactive protein, and even in patients who are HLA-B27 negative. And this was from the Invigorate-1 study, which is this IV secukinumab study. The next two papers I'm going to describe are bimekizumab's effect on radiographic progression and on the changes on the MRI, inflammatory and structural lesions. This particular abstract is abstract number 1757 by Walter Maximovich, looking at bimekizumab treatment over 52 weeks from two phase 3 studies that we already discussed, B-Mobile 1 and B-Mobile 2. And these are data showing the changes in the MRI, inflammatory and structural lesions in the sacroiliac joints. Bimekizumab showed that it not only reduced the active inflammation in non-radiographic axial spondyloarthritis shown on the left top in the figure, but also in the radiographic axial spondyloarthritis. And these are absolute scores of inflammation dropping in radiographic and non-radiographic axial spondyloarthritis. And the table at the bottom shows patients who reached MRI remission. Now, the definition of MRI remission is the SPARC score of less than 2. And the percentage of patients who reached that remission from MRI inflammation point of view is about 66% at week 16, and actually 80%. And this is for non-radiographic axial spondyloarthritis, which is very heartening, I would say. And about 56% at week 16 and about 75% at week 52 for radiographic axial spondyloarthritis, which is also very, very good. So bimekizumab completely abrogates the inflammation. What was interesting was there were substantial reduction in erosion scores, also not shown here on the figure, but there is a figure in the actual abstract if you want to go back and take a look at that. And there was an increase in the backfill and fat lesions, and that might be alarming to some people, but that only shows that there is a repair going on in a way in the sacroiliac joint of these patients. And there's nothing to worry about. Actually, erosion scores go down. So bimekizumab had a substantial impact on the sacroiliac joint MRI inflammation and structural lesions, suggesting tissue repair. And the next one is poster 1758, and this is by Xenophon Baraliakos. This is looking at the X-rays. The previous one was MRI. Now we are looking at the X-rays. These are 2-year results. And this was from a single study, the B-Mobile 2 study, which was radiographic axSpA. Patients with non-radiographic axSpA, they didn't really have their X-rays repeated of the spine, because we are going to look at the MSAS, modified Stoke ankylosing spondylitis spine score on spine. This is lumbar spine and cervical spine. And there was minimal spinal radiographic progression in patients with radiographic axSpA treated with bimekizumab. If you look at the cumulative probability plot shown on the right-hand side, what you will see is 83% of the patients had no progression at all. Actually, 85% of the patients had no progression whatsoever. The median or mean progression was 0.3 MSAS. MSAS goes from 0 to 72. And 0.3 is literally no progression whatsoever. That's the average progression in these patients. And then they looked at patients who already had syndesmophytes, because that's a risk factor for developing new syndesmophytes. And there were 30% of the patients who had, at baseline, they had syndesmophytes before entering into the study. And if you look at those 30% of the patients, only 1/5 of them, 21%, had a new syndesmophyte. And if you look at patients who did not have syndesmophyte at the baseline, only 1.5% of the patients had new syndesmophyte. In short, there is very minimal spinal radiographic progression of 0.3. And just to give you an idea about how much MSAS progression we are used to seeing before the biologics came, we used to see between 1.5 to 2 MSAS progression over 2-year period, 1.5 to 2. With biologics, it dropped to 1, and now we are getting at 0.3. This is really, really minimal radiographic progression. I go back to bimekizumab. This is achievement of remission defined by absence of objective signs of inflammation. This was a poster by Leanne Gensler 2362 is the poster number. Now, there are two ways of looking at or deciding whether a patient is in remission or not. One is, of course, looking at ASDAS. ASDAS is ankylosing spondylitis disease activity score, and less than 1.3, it's not technically remission, it's called inactive disease. But be as it may, if inactive disease equals to remission, that is one way of looking at it. But the second way to look at it is to look at the objective signs of inflammation, and those are C-reactive protein being high, and also MRI changes on the sacroiliac joints. And also also the MRI changes on the spine. So MRI changes on the spine are looked at by Berlin score. MRI changes on the sacroiliac joints are seen by Spark score and the CRP. Those will be the objective signs of inflammation. And the bottom line is there are more people who get the remission as defined by absence of objective signs of inflammation compared to those patients who actually get remission as defined by ASDAS less than 1.3. And so, in other words, bimekizumab is putting more people into inflammation reduction than what can be decided based upon the ASDAS score. And the reason is that ASDAS has, apart from CRP, the rest of ASDAS consists of patient-reported outcomes, pain and stiffness and etc. And those are, even though we call them parts of the disease activity, they are not objective signs of inflammation. So ASDAS inactive disease could in fact be underestimating the anti-inflammatory effects of bimekizumab. So the bar graphs that you're seeing on the right-hand side, on the left-hand side you see is the bar graph which showing the changes or the percentage of patients in remission according to objective signs of inflammation. On the right-hand side, you're seeing the patients in remission based on ASDAS score of less than 1.3. So I thought this was an interesting way of looking at remission by two different definitions. And the last abstract I have is again about bimekizumab. Bimekizumab has a warning about suicidal ideation, etc., which the other IL-17 inhibitors do not have. Now, of course, bimekizumab is IL-17A plus F. The other two IL-17 inhibitors are purely IL-17A inhibitors. And so there has been a question about the mental health and suicidality in patients being treated with bimekizumab. So I thought this was an interesting and important abstract. This was 2364, presented by Marina McGray, reporting mental health and associated disorders from trials of bimekizumab in patients with active axSpA and psoriatic arthritis. These are pooled data from axial spondyloarthritis and psoriatic arthritis. Two studies from axial spondyloarthritis, B-Mobile 1 and 2, and two studies from psoriatic arthritis as well. And they specifically looked at suicidal ideation, they looked at depression, etc. And interestingly, there was absolutely no difference between bimekizumab and placebo. And the numbers were extraordinarily low. These suicidality and all these SIB, as they're called, they were looked at by using this ECSSRS, which is a score for depression and suicidality, as well as PHQ-9 scores. The numbers or the scores were low to start with. And at the end of week 16, the adjudicated suicidality and anxiety and depression rates, they were very low, and they remained low for up to 1 year. And there was absolutely no difference in the first 16 weeks between the patients treated with bimekizumab and placebo. The reason why the warning was given was because of a single patient who committed suicide in the psoriasis patient treated with bimekizumab. We haven't seen that occurring in psoriatic arthritis and axial spondyloarthritis. Thank you. That's the wrap-up of the axial spondyloarthritis presented at ACR 2024.
Well, that's all we have time for, folks. I hope you've enjoyed this review podcast. Don't forget to visit the IMID forum, where you will find a range of great content, including detailed slide decks of the top research, monthly podcasts, and even special webinars around key topics of interest. Thank you, and as always, best of luck in your clinical practice.